Good evening, everybody. Thanks so much for joining the piezo-wave open forum discussion tonight and presentation. We are very excited to have Dr. Ronald Koh with us tonight. He is a board-certified sports medicine practitioner, as well as multiple other certifications that you can see after his name on his first slide. I met Dr. Koh when I first started with Elevation and the piezo wave. He is an exceptional teacher, so I do look forward to hearing from him tonight. Please do help me and mute your microphones during his talk. I know a lot of us are still working, taking care of families, etc., etc. So if you would help us out by muting your microphone. I am watching the chat and we will have some time for questions. So I find during questions, some people don't want to speak up. Not a big deal. Write a question in your chat. We are here to explore everything we can about navigating IVDD recovery. So I will turn this over to Dr. Koh and enjoy.
Thank you, Cindy. Hi, everyone. Good evening, good afternoons, or good morning. It depends on where you're from. So thanks again joining for the webinar. So today I'm mainly just kind of share my experience, how I navigate IVDD recovery, and mainly phase by phase, how I design my rehab program for my patients, and something that I would like to share with you. I don't have anything to disclose other than I am a professor at the Chi University. So the outlines, including I will go over or review the background of IVDD. I also will look at the phases of IVDD recovery, which include acute, subacute, and chronic phase, and how we're gonna design our treatment plans. And most importantly, I will spend some time talk about how to optimize pain management using multimodal approach, especially for those non-surgical candidates that we absolutely need to focusing on a better plan to control the pain during the recovery. And lastly, we will talk about how to apply safe, phase-appropriate rehab techniques to reduce pain, improve neuroplasticity, and also restore mobility. So let's start with a quick review of IVDD. It's a broad term that simply means the disc is abnormal and is affected by the spinal cord. In dogs and cats, degeneration of intervertebral disc causes loss of hydration and integrity of the disc, which predispose the disc to injury. Traditionally, we describe two main forms, Hansen type 1, or we call IVD extrusions. This is the classic chondrodystrophic dogs like Dachshunds. The nucleus pulposus acutely extruded through the rupture annulus, often with a very sudden onset of pain and neurologic deficit. So this type of patient usually experiencing a lot of pain that we need to do better for the pain control. Hansen type 2, which is IVD protrusions. This is more a chronic progressions, annular thickenings and bulgings, and gradually compressing the spinal cord, so-called bulging disc. Happen more common in larger dogs, older dogs as well. In cats, IVDD is less common, but when we see it, it's usually in the older cats with type 2 IVDD, like protrusions, or occasionally we see traumatic extrusions. Now, over the last decades, our terminology for spinal cord injury has become more refined. You will see several neuro subtypes. The most common one would be FCE. Technically, it's a vascular event, not a disc compressions, but it lives in the same differential list. Every time patient that paralyzed, having trouble walking, FC always our differential diagnosis. ANMPE usually caused by a high velocity extrusion of the disc material that shoot into the spinal cord that causing pain. But there's a little to no residual compressions. So usually it's not a surgical case. HMPE, it's caused by a hydrated material extruded into the spinal cord and often causing some ongoing compressions. However, nowadays, neurologists, they don't do surgery on HMP anymore because based on literature, the outcomes comparing conservative management and surgery for HMPE are quite similar. So a lot of time that we just treat them conservatively with rehab and pain control, crate rest, they might give us the same results. But anyway, so getting a clear terminology is very, very important because it might affect your treatment plans, outcomes, and prognosis. So in other words, getting a diagnostic test sometimes is very, very important so that we able to tell the owner what would be the prognosis. Now, clinical sign-wise, those patients are going to experiencing a combination of pain and neurologic dysfunctions. For pain, we always seen they might have cervical, thoracolumbar hyperesthesia, and neurological-wise, we can see a spectrum from myotaxia or paresis to paraplegia, depending on the lesion's location and how severe it is. A key concept is that every time that dogs have some called injury, especially IVD, IVD or IVDP, it's going to be ascending loss of functions. First, they're going to lose proprioceptions, then motor functions, then superficial pain, and finally deep pain. So again, this guides us like how severe the neurostatus is and how we gonna talk to the owner about prognosis or treatment plan as well. And also very, very important that using this concept, when we do rehab, we should see a reverse improvement of those clinical signs. Diagnosis-wise, but we all know that the first step is do a very good neurological exam that you help us to localize the spinal cord segment, which segment is being affected. Then either we want to focusing on the area doing imaging, or we want to do like laser, acupuncture, whatever treatments, focusing on that suspect lesions. Radiology, radiograph is always the first step that we would do, but we all know that it has limited sensitivity diagnosing these problems. MRI is still the gold standard. CT can be helpful, especially when you combine with contrast. Now, when MRI, CT are not available, nowadays, some veterinarian, they might still consider myelography to diagnose IVDD. It's not common anymore, but it's still been practiced in some countries. There's several validated spinal cord injury scales out there. So the most common one that we use is modified Franken scales, MFS. It's an easy way to determine what's the neurostatus of the patient, but you could also use other more detailed scales, like open field scales or Texas spinal cord injury scales. They are all validated scale for IVDD. Management-wise, it depends largely on neurological grades and the rate of progressions. On the conservative management, this works best for dogs with pain only or mild neurologic deficit. This is a case that usually we would recommend strict crate rest, typically 4 to 6 weeks. And very importantly, we always want to start early neuro rehabilitations because we know that we could use modality for pain control, we could use manual therapy and help to maintain range of motions, muscle mass, stuff like that. So neuro rehab definitely something that we always want to focusing on. And depends on the stage of the injury, then we designed a individualized rehab plan for our patients. Now, pain medication-wise, typically we give NSAID or tapering dose of prednisone, or you can add gabapentin for nerve pain, metocarbamol for muscle relaxants, or even some cases we use opioids, especially when they're very painful. On the surgical management side, dog with moderate to severe neurologic deficit or persistent or recurrent pain or loss of deep pain, they are strong candidates for surgery. Again, even for surgical cases, post-operative neurorehabilitation is critical. That we still need to design a individualized plan to help them to recover from surgery. Let's talk a little bit about prognosis. This is one of the important things that you need to know. And also you need to know to able to tell the owner so that they could make a decisions whether or not they need to go surgery or like what they should do. Okay. In dogs that are ambulatory with deep pain, the prognosis is always good. About 90 to 95% will recover, often within 12 weeks, with the median around 11 days. For those non-ambulatory dogs, but still have deep pain positive, the prognosis is still good, roughly 70 to 85%, especially when we're able to start like rehab, crate rest, medication. So those I think that could help them to improve quicker and increase the success rate. Now, once the dog becomes deep pain negative, prognosis can become harder to poor. With early surgery, some of them will recover. Studies show that around 50% they will recover. But again, the recovery can be slow in some cases. Also keep in mind that there's a subset of deep pain negative dogs. They may become a spinal walker, which is a reflex-based gait without a true supraspinal control. And it is actually the percentage for those dogs become a spinal walker can as high as 60% based on literature. So this is good news. Even though dogs does not have deep pain, with the strong upper motor neuron reflexes, like young dog, active dogs, you can actually train them become a spinal walker. Okay, early study, about 30% of them become spinal walker. In a 2017 study, 60% of the dogs with no deep pain become a spinal walker. Now, the Gallucci study even showed that younger dogs, which is younger than 5 years old, less than 8 kilograms, started early rehab. Those patients have a better chance to become a spinal walker. Most recent study, which is in 2023, again, almost 60% of the dogs with no deep pain to become spinal walker. The median time would be 2.5 months, range from 16 to 350 days. So this is telling us that, again, there's a chance that for those dogs become a spinal walker, they need to start the rehab as soon as possible, especially that you want to do a lot of gait patterning. Now, it takes almost up to 350 days to become a spinal walker. So there's something that you need to tell the owner that, like, do not give up too early. I usually tell the owner that, like, give me, if you really want the dog to become a spinal walker, at least that 6 months to do an intense rehab. And then we can see whether or not it's successful. Again, if that doesn't work, at least that the dog will still get a good rehab to strengthen other useful limbs. But if not, then I think that's unfortunately that's going to be the case. Okay. One thing about those spinal walker, they never recover either urinary or fecal incontinence. Now let's talk about neuro rehab. So neuro rehab is really the process of restoring and maximize functions after the nervous system has been injured or compromised. When we think of neuro rehabs, I want you to think beyond just exercises, because rehab involve other area, not just the exercises. And we try to use some evidence-based approach, including pain control, neurologic trainings, environmental supports, or even owner educations. Okay, so the key benefit including we want to do everything, not just help the dog to recovering, but also teach the owner and how to take care of the pets, because it's not going to be just a 1 week or 1 month of treatment. It's going to be at least like 3 months, 6 months, or even up to a year of treatment. So definitely need to spend some time to do client educations. And here is the 3 phases, how I use it to design my structured rehab. And those 3 phases is based on healing stage. Every time when tissue injured or after surgery, they always have to go through 3 phases. Your inflammation phases, which is phase 1 in rehab. This is a phase that we want to provide care and environmental modifications, which we'll talk about that later. Most importantly, we want to focusing on inflammation and pain management. Again, we would talk about that, what modality that can be used to help with that. We want to maintain range of motion, muscle flexibility, and tone, so that when the dog regain their nerve functions, they get ready to use the limb. So that this is a phase that we want to get everything be prepared, so that in case that the dog want to walk again. We also want to stimulate nervous sensory motor inputs, so that we want to reconnect the spinal circuitry or wiring, so that the nerve able to function again. So this is phase 1. You can see that phase 1, I don't do a lot of exercises, because phase 1, the dog is still inflamed and painful. They need to be rested. We're mostly focusing on pain medications, resting, and manual therapy. Now, phase 2, which is subacute phase, where the inflammation, pain, they are reduced or they are gone, but then the body need to heal, the tissue need to heal, regain the strength before the tissue able to function again. So this is the phase that we also want to go slow with our patients. We don't want to just throw in a lot of exercises and they might re-injure themselves. However, we do want to start re-educate the muscles, the joints, and then also the nervous system, so that we step by step, we help them to regain the functions safely and prevent any secondary injury. Okay. Phase 3, which is chronic phase, once the patient able to bear weight, then we would talk about how we could progress our treatment plan to restore the strength, endurance. Ideally, we want to get them to back to normal as much as possible. Some cases, yes, we actually can do that, but some cases, unfortunately, they might still have residual neuro deficits, no matter how long have you been working on them. Okay, I feel like we still don't know the exact protocol to help those patients. But I think that's as long as you treat them, like design the exercises specifically for them. If they have poor proprioception, you want to do more proprioceptive exercises. If they have less strength, you want to focusing on strength exercises. So this is a phase that it really depends on what the patient's needs, what still need to be strengthened. Then you kind of focusing on that area. Before I get into those exercises, this slide show you a concept that I just mentioned about. It's very, very important for both prognosis and rehabilitation sequencing. The order in which the neurologic functions are lost and then how they would regained. So every time when the patients have a spinal cord injury, it depends on how severe the compression is. The first thing that it would affect would be proprioceptions, and then would be the motor control. They might lose some strength and become paralysis. And some patients, they only have ataxic. If the motor is lost, they will become plegia. And then after that, they might lose their bladder and tail functions. And eventually they might lose their superficial pain and deep pain. Now, the recovery happened in the exact reverse orders. So if the patient knows deep pain, we need to regain the deep pain first. Otherwise, that they're not going to be able to regain the other functions, the tail, the bladder, the motor, the proprioception. Okay. After they regain the deep pain, then would be the superficial pain, and then the tail function. This is why that every time if I see dogs start wagging the tail, I'll be very happy. I will share the good news to the owner, say, your dog start wagging the tail voluntarily. So that's a good news. That's like meaning that the dog might regain some motor, and then they might see some bladder functions regain. They might be able to hold the urine better. They might be able to urinate a little bit better. So that's a good news. That means that the motor function slowly gain back. So then after motor function regained, we want them to be able to bear weight. And after that, we would train for proprioception. Proprioception is the last to come back. It's also the most difficult one to regain. Sometimes it takes months or even years for them to regain. Okay. Again, at this point, I not only just focusing on proprioception, I also focusing on strength, because regaining the strengths actually able to help the patient stabilize themselves. Even though they have proprioceptions, they might be able to pick up the leg better and walk forward without dragging the hind paw that much. So phase one, it's also very important that we modify the environments and take care of them. So this is the things that I would teach the owner to do. I'm sure you probably know how to like talk to the owner about this. Make sure that no non-slip floorings, using the sling and harness, providing soft bedding for recumbency, easy access to feeding or water bowls. Tell the owner how to express the bladder correctly. And they might need to wear diapers. Again, you might want to provide step or ramp for them to safely go up and down the couch, the bed, wherever it is. Okay. And keep in mind that dogs, they can be stressed out as well. Okay. They often become anxious, frustrated, fearful after losing mobility. So you need to do something that to help to calm them down, provide more interactions, pheromones, supplements, music, anything that could actually help to calm them down. Most of the time that we always give them gabapentin, trazodone during quick rest. That also is a good idea because it also provides some sedative effect that help to calm the animals down. All right, next we'll talk about phase one. Okay, phase one, like I say, we're more focusing on pain control, and medication still is the cornerstones. NSAIDs combined with gabapentin or pregabalin. Like I say, you could also combine with metocarbamol, opioids if needed. Okay, beyond medication, quick rest again is very, very important. Cryotherapy can be useful for the first 3 days to reduce inflammations, and after that, you could switch to heat therapy that help to increase circulations to promote healing process. I always incorporate manual therapy, either do it at the clinic or I teach the owner how to do some manual therapy at home to improve their sensory motor input at the same time relaxing muscles. And acupuncture is one of the most powerful tools that I found is very helpful for pain control and also help to stimulate nervous system and increase neuroplasticity, which is very, very important. I will talk about that later. Electrostimulation, 10 units, good for pain control, and MES is very good to preserve muscles, especially when the dog is not using the limb. You want to start using 10 unit to contract the muscles for 10, 15 minutes once a day, just to preserve the muscle mass, because losing too much muscle actually will slow down the progressions, and also provide a poor prognosis. Laser therapy, shockwave therapy, pulse electromagnetic therapy can be used as well for pain control. And some of the modality actually have shown that it increase neurotropic factors that might help to increase nerve regeneration, remyelination, stuff like that. Again, we'll talk about that in the next few slides. So acupuncture, it is not just for pain. In neurological conditions, there's a lot of study also have proved that it has direct neuroprotective and regenerative effect. For example, increased neurotropins, BDNF, CGRP, oligodendrocyte precursor cells. Those factors very, very important to support synaptic plasticity, remyelinations, and also regenerations. Okay? Acupuncture also reduces apoptosis and decreased axon loss, which help to preserve those surviving neural pathway. And overall, it promotes neuroplasticity, which is a important things to help to recover their nervous system. So this is why that this is a phase that I absolutely would recommend acupuncture for my patients. Laser therapy, for those that do laser, you know that it helps to increase ATP, which help to regenerate tissue or speed up the tissue healing. We don't know at this point whether or not it could penetrate deep to the spinal cord to regenerate spinal cord, but at least that we could use it to treat surroundings tissue injury and also reduce the inflammations. It also decreased apoptosis and gliosis and improve microcirculations. Again, that it's important, especially during recovery. You want those kind of microcirculation to increase that perfusion within the spinal cord that might help to speed up the healing process. So laser therapy definitely is something that I would do either once a week or twice a week along with acupuncture. PEMF, it's also very common, used in clinic or at home as well. It had found to reduce neuroinflammations by decreasing different kinds of cytokines. It also enhanced neuronal repair and plasticity. BDNF, NGF, and those are important factors that help to regenerate axons. It also protects the nerve as well. So this is a modality that's again, I'm sure that if you guys do rehab, you have the PEMF mat. So the dog's lying on the PEMF mat, you do acupuncture, you do laser. So that's something that's on top of what you're doing and might provide additional benefit. I also would tell the owner that they can buy the CC loop or the PEMF loop. Now there's another company that's selling the loop. So either you can get a CC loop from that company or another company, I think it's called PEMF Pet. They starting to sell a loop. You can use that for, you can have the owner to use it at home during recovery as well. Shockwave. Now, shockwave, many of you feel like it's good for musculoskeletal problems like tendon, joints, arthritis, but it also has a fascinating neurological effects. When you look into literature, shockwave actually have found that it increased VEGF expressions, which help to promote vascularizations, again, which is benefits spinal cord injury by increasing the perfusions within that lesions. It also increases nitric oxides, which also improving microcirculation and relaxing the smooth muscles. And even literature have shown that it helped to boost BNF expressions. Again, one of the factors, like I mentioned, it's very good for nerve growth and proliferations, and also for repairment as well. The other thing that shockwave have been found is it increasing a factor called PCAM and SDF. And those things actually involve in stem cells recruitment and endogenous tissue regenerations. Again, all those things that work together so that it could really promoting the regenerations of the soft tissues, not only the spinal cord, but surrounding the lesion and even for surrounding muscle as well. Because we know that shockwave is very good for releasing or relieving muscle spasms, things like that. Based on literature, what worked the best is giving a low dose of shockwave once a week for a couple of weeks. That's how that it helped provide that kind of benefit. Some study looking at high dose, but I remember there's one study comparing high dose and low dose. They found out that low dose actually provide a better pain relief and also regeneration compared to high dose. Now, when it comes to dogs, we don't have a lot of literature to use modality for IVDD, except for acupuncture. This is actually the newest study that came out this year. I still haven't not able to get the full paper, but this is the abstract. It's a pilot study looking into shockwave for lumbosacral pain in dogs. There's a 10 client-owned dogs treated with shockwave on day 0, 14, and 28. The results show that 60% of the dogs show clinically improvements, more than 2 points on the CBPI. All the CPI significantly drop by day 14, 28, and day 60. As you can see that day 60, it dropped almost 3 points, which showed the most significant improvement. So again, this study have concluded that shockwave significantly improved lumbosacral pain in dogs based on CBPI. Now, again, this is not specifically IVDD case, but it kind of reinforced that shockwave does have an analgesic effect, and that might support spinal health and functions when we use it appropriately. Again, eStim is another modality that's commonly used in rehab therapy. What it does basically is help to contract the muscles and provide a strong muscle contractions that help to prevent or slow down the muscle atrophy progressions. 35 hertz is the one that have found to produce a strong muscle contraction that help to prevent muscle disuse, maintain muscle mass, but does not cause much of muscle fatigue. So we tend to use 35 hertz. But again, different literature might tell you a different hertz, but 35 hertz is just the one that I commonly use. Okay? I use it 10 to 12 minutes once a day during the time that dog's not able to ambulatory. Now, if the dog able to ambulatory, you probably don't need to do that, because if they're able to contract the muscle voluntarily, you actually need to focusing on like training them, doing exercises to contract more of the muscles, not necessarily need to rely on using modality to contract the muscles, because voluntary contraction is always better than non-voluntary contraction. So this is still a phase 1. Like I say, I use a lot of manual therapy, focusing on sensory input, gentle mobility, and also basically that I use those things to hopefully to improve the motor control and facilitate and enhance the muscle activity. After the pain is better, after the motor is better, then we can start doing more exercises. And by doing manual therapy ahead of time, it basically helps the muscle be prepared to do those kind of work. So I do find out that they recover quicker. I kind of divide it into 2 different categories. One is the tactile stimulations. So I use like tapping, brushings, use vibrations, quick stretchings, or even a short application of ice. Sometimes you can like stimulating the muscle contractions, and that provides sensory feedback to the spinal cord. The other category would be soft tissue and joint mobilizations. Again, massage stretchings is always good to addressing any kind of compensatory tightness. Passive range of motion, bicycling, it's very easy to do. That help to maintain range of motions, right? And also like help to provide some gait patterning during the recovery. Joint compression, traction, gliding, it's just another type of treatment that may able to activating your mechanoreceptors within the joint. The the joint that have the most mechanoreceptors in the hind limb is the knee joint, right? I will do a lot of compression on the knee joint, gliding. So kind of activate those mechanoreceptors as much as possible. In the front limb, elbow is the one that has the most mechanoreceptors. So that's the one that you need to work on when the patients have front limb being affected. Here are just a few videos. Again, for those that are doing rehab, you're probably very familiar with those. So passive range of motions, bicycling. So that's the one that I extend all the joint, flexing all the joints. I also would adding toe pinchings. When I extend the joint, I pinch it so that it induces the reflex, which the dog will flex the joints. Then I will extend again and I pinch it, they will flex it and keep doing that. So you basically kind of doing like half of it and the dog do half of it, right? So you extend it, they are the one that like flexing it, okay? So it's a very good kind of exercises to do that. Tapping, so again, tapping the muscles, kind of contract the muscles. Now, when I tap the quad, I extend the knee joints because when the quad contract, it will extend the limb, right? Now, when I flex the knee joint, I tap the hamstrings. I just kind of go and do that kind of couple like minutes to facilitate that sensory input. Brushing as well, okay? When I extend the joints, I brush the quad. And when I flex the joint, I brush the hamstrings, okay? So this is, again, toe pinching that I show you. And when I do toe pinching, sometimes I do tug of war. It's a very good way to contract the muscles, even though it's not voluntarily, but it's still good that the dog, they contract the muscle themselves rather than using the e-stim, right? So when you pinch it, they will flex it by contracting the hamstrings, but you kind of keep pulling it, let the muscle contract for a few seconds before you let go. So it's a very good way to stimulate that. Now, manual therapy is always be creative. So this is dog paralyzed for 3 months. So I just think of, well, why don't I just like use the hind limbs to scratch the face and end up that the dog really enjoy me doing that. Imagine that like the dog has not been able to do that for 3 months. And now that you do it, you can see you literally can see his face. Like he's like, okay, that's good. Now again, even though he's not doing it, you are the one doing it, but that actually, it was still stimulating that spine circuitry so that like keep sending that sensory to the spinal cord and to the brain as well. So again, to me, that's very, very important to kind of connect that the nerve, okay? You also want to start doing some positioning and transferring. I tell the owner that put the dog on a sternal position as much as possible. I don't like to let, I really don't like them to lie on laterally for a very, very long time. It's not good for the muscles. It's not good for the lung, right? So I tell the owner that put them on a sternal position as much as possible because, well, think of this, like when the dog get ready to get up or stand up, the first thing that they need to do is like in a sternal position before they can stand up. Or it would be easy for them to stand up when they on a sternal position. So that's why I would want to train them to able to correct themselves on the sternal position so that if they're ready to push themselves up, they can safely and more effectively doing so, right? As opposed to if the dog is lying down, if they try to get up, you always see that they're kind of struggling just because they could not get the good grip to help them to get up. So how do I do that? Again, this dog is tetraplegia due to cervical injury. So I'm just going to push them and let them contract the muscles and do that. Try to do that themselves. I just kind of push them. And then at the sternal positions, I let them stay on that position for a few seconds before I do the other side. So I just keep doing that over and over again for a few minutes. So this another one is bouncings. So that's the one that I would extend the hip joints and the knee joints, let them stand straight. This dog still not able to bear weight herself, But what I did basically, I just extend all the joint and I bounce it. Okay. Now, small dogs, it might be easier for you to extend using your hand to extend the hip joint and the knee joint and bounce it. If it is a big dog, what I would do is that I would extend the joint and I have technicians to bounce it from the pelvis. Okay. So after the bouncings, now bouncing, when you when they do the bouncings, when they put pressure onto the joints, it do compressions. It also would activate the muscle to contract. So it's a very, very good way that to again, not only help to preserve the muscle mass by muscle contractions, but also help to improve that sensory and motor input. Toe pinching, I also do that when they're standing, right? So when they're standing, I kind of pinch one toe. Now, even though the dog does not have cross extensor, positive cross extensor, upper more neurons, this actually is a very good exercises. Remember that when the dog is standing, they always have a cross extensor reflex, right? Because they need to, when they flex one leg, the other leg has to push down to bear weight, right? So this one thing that I like to do is have them stand up, pinch the toe. When one leg is being flexed and the other one would kick, and then you can keep doing that on both sides. So this is phase one. Okay, so again, you don't see me do a lot of exercises because again, too early exercises can actually cause secondary damage. So I'll probably do it for 2 weeks, 3 weeks, or 4 weeks, depends on how quick they recover in terms of pain and inflammations. Once the gets better, then I will start getting into phase two, where rehab become much more active. So we're focusing on retraining the gait and improving motor coordination. We encourage appropriate limb loading. We want to improve proprioception and balancing. At the same time, we also want to preserve muscle mass and build the muscle strength. Okay, so this is a phase that it's all about consistent, repetitive, and purposeful movement. So you have to do a lot of gait patterning in this phase, especially those dogs that you need to train them become spinal walker. This is a phase that you always need to do a very, very intense gait patterning, assisted walking, so that they learn how to do those gait patterning to help them to get back and using the limb again. So what is the evidence of locomotor trainings in spinal cord injury? It's, well, for one thing, it's very, very important. These actually have been proved across human literature and also lab animal studies. Even though we still need to do more study on dogs and how that locomotor training could help to improve the mobility. But if you talk to any like physical therapists or anyone that do neuro rehabilitation, locomotor training is absolutely important because it promotes spinal neuroplasticity, which is essential to waking up the spinal circuits that control the stepping. It also increases neurotropic factors like BDNF and T3, again, which very important to regenerate nerve and the nerve rewiring. Okay. Locomotor training also help regulate metabolic and physiological environment of the spinal cord, which might help to improve the nerve communications and also adaptations. Okay. Again, study across species consistently show that the timing of rehab is very, very important. The best outcomes is to start the rehab early, again, but not too immediately after the injury, because like I say, you still need to allow the spinal cord to be rested during inflammation phase. But after inflammation gets better, then we need to start doing locomotor training. So gait and step training is one of the things that is of importance. You could use the land treadmill, right? Using the sling, using your hands, stimulating them walking. If they're not gait patterning, you then have to go to like help them to do the gait patterning. I always stimulating the tail and the perineal area, just kind of stimulate them taking the step. So this is the dogs that have no deepen, and actually training the dog to become a spinal walker because he has a strong reflexes. So I put a TENS unit on the quad, the glutes, so that when the dog taking step, the electrostimulation also stimulating the nervous system. I actually also like stimulating the perineal area. I even stimulating the anus. Okay. So it looks like I'm pulling the tail. Actually, I'm not pulling the tail. So I'm actually kind of holding the tail and pinching the tail. So I never pulling the tail just to support the back. Never do that. Okay. So you might damage the sacrum and the tail as well. Okay. So you can just give us like supports and pinching the tail, and you want them to like using the limb to support them. So underwater treadmill is another one that you could do gait patternings, right? So it kind of the water float them, especially when the water level is at the hip joint or the shoulder joint. It takes up about 60% of the body weight. And you can do stimulating the tail to help stimulate them to take step, or you can just have to go down there and using your hands to do the stepping. Now, perineal stimulation is not something that I made up. It's actually been studied quite a lot in the past decades. I don't know if you noticed that, or if you've seen that kind of study, which is actually pretty cool. Perineal stimulation is a very useful technique that I borrow from a spinal cord injury research, mostly look at cats. When you stimulate the perineal regions, it triggers the spinal excitability, which can help to facilitate the hind limb stepping, especially useful when they have a severe paresis and plegia. So let me show the videos and you will know what I'm talking about. So this is the cats could not bear weight, and those cat actually is no deepen. They all purposely cut the spinal cord and become plegia. And when they stimulate the perineal regions, you can see that they really kick the back leg because of the excitement that happens within the spinal cord. So this is a comparison. On the left-hand side, it's without that perineal stimulation. On the right-hand side is with the stimulations. So you can see that big difference when they taking step. They're all the same cat. You can see that on the right-hand sides, they take a really good step and stronger steps compared to the one without the stimulation. So if you are not doing this yet for your neuro patients, I hopefully that you will learn at least one technique today that you could help your patients doing your neuro rehabilitation. In the water, always be creative because the water can float them. So I could do sit to stand, I could do side stepping, I could do backward walking. Small dog, you could even do like circle, figure eight in the water. Okay, not necessarily have to turn on the treadmill because some dog doesn't like the treadmill. So you just need to be more creative. Again, we're still in phase 2. Some other exercises that I would do would be same thing: passive range of motion, bicycling, gait patterning, with or without support. You could assist them using the harness or the therapy. For small dogs, you can just use a pillow or roll towel and do that. Okay, and this is a case that how I do my gait patterning and stretching. Not stretching again, the toe pinching. So these dog actually get scalp acupuncture. At the same time, I do exercises. So I pinch the toe and cause some reflexes. I just keep doing that. Ideally, I would like to put both, like my left hand on the left hind limb and right hand on the right hind limb, so that I can do both sides at the same time. Yeah, but the dog not able to support fully the back end, so need to support the hind limb. So again, anything that you could stimulate them to get up using the hind limb, right? So this is a dog that has some congenital spinal cord disease that causing ataxia in forelimbs. So again, this dog is very foot motivated. We just use the treat just to lure him, try to stand up on her own, and also step on the bouncing disc. Now, if the dog does have trouble sitting and getting up, especially big dogs, I just let them sit on the stack pillow. And then as they get stronger, I take off the pillow one by one. You just need to help them like able to, because if the dog sit on the floor, she would not able to get up because she's so weak. So, but with the 3 pillow, you can see that she can do that little by little. And then like now, 3 pillows, it's good. So I take off 1 pillow and I have the dog sit on 2 pillow. Okay. Again, educate not only gait patterning, but also balancing and core muscles, right? So have the dog standing on the bouncing disc, doing the bouncings, kind of reinforce the muscle contractions and also the core muscles at the same time. So rocker board, same thing as well. And don't forget about assisted walking, because again, assisted walking is one of the good way that to train them to able to pattern the gait, and then slowly, hopefully that they're able to pick up the normal pace. That's how that we know that they're improving. Now, the problem about that is that a lot of time that they still have poor proprioceptions. So when they walk, they might drag the paw, they might drag the toe, so they might cause secondary injury. And always good to use something to help to improve the proprioceptions, like DIY TheraBand to flex the torsal joint. You can use toe-up sling, dorsiflex, rare no-knuckling training socks, Bico band. Those are things that you can buy over the counter and help your patients. Okay. Now, like this dog, I use the toe-up sling. I mean, he's still kind of scuffing the hind paw. So what I did, I end up adding a TheraBand. You can see that now he could walk better without scuffing the hind paw. So sometimes you just kind of have to combine both together to give you the most benefit. And of course, then you need to start training them proprioceptive trainings. So hopefully eventually that they able to regain their proprioceptions. All right. So again, phase 2, gait patternings, weight loadings, you can throw in some balancing exercises. Again, we're still not going to do a lot of strengthening exercises because the tensile strength of the tissue might not still strong enough. So once they're able to walk a little bit better, bear weight a little bit better, then you can go to phase 3. Okay. Phase 3, usually the dog should be ambulatory. They are coordinated enough that you could add more exercises to strengthen the muscles, improve the proprioceptions, and even help to improve the endurance if needed. Okay, so the goal would be, again, proprioception, strength, endurance, return to full or normal functions, and of course, managing any kind of compensatory pain or any kind of restrictions. Because they are still not fully recovered, you're going to expect that they might always use the front limb, the neck muscles, right? So especially for older dogs, they might already have some arthritis in the shoulder, in the elbow. They might already have some IVDD in the neck. If you don't protect those areas, you likely going to looking into causing a secondary problems, right? Even though the dog recover from the IVDD, but then you need to deal with the severe arthritis or another IVDD, possibly in some other area. So don't worry, don't overlook the compensations that you need to deal with. Okay. So proprioception wise, wobble boards, trampolines, sidestepping, pivoting are the basic thing that help them to take steps that help to improve the proprioceptions. And also for balancing as well. Okay. Weaving, circlings, figure 8, cavallari, ascending or descending steps. So this is just a exercises, figure 8 exercises. Again, owner can easily just use the limb as help, like allow the dog to do the figure 8. Okay. The weaving, right? So again, this is a dog that having trouble walking. He could bear weight, but we're just adding some exercises to help to improve the bouncing and proprioceptions. You can make it a little bit more challenging, right? So weaving, adding the bar, just kind of not only challenging the bouncing, but also proprioception at the same time. Just pretty much anything, right? So steps, just kind of put random thing on the floor and have the dog walk up and down of those things. Walk a couple times, walk up and down of the stairs, anything. Walking up, it's very helpful for strengthening the hind limb, and walking down, it's good for the front limb. Other exercises for strengthening muscles, sit to stands, platform, or steps. Have the dog front limb step on a higher ground or a higher object. Gonna shift the body weight to the back legs, because a lot of dogs, especially small dogs, so when they recover, they might pick up a bad habit where they would put more of the weight on the front limb. So it make them, every time they get up, they use the front limb to get up rather than using the back leg. So you need to train them to able to shift that body weight backwards so that they start to use the hind limb more in order for them to stand up and to walking as well. Okay, so those are exercises that are important. Walking backwards, same thing, have the same effect. So when the dog walk backwards, they're gonna shifting the body weight backwards to the hind limb. Okay, incline, decline, or even hydrotherapy. Good. Okay, last one. So there's probably one thing that people always ask, like, when should I start wheelchair or cart for the dogs? Okay. I don't have a good answer for that, but I usually try to avoid putting the dog in a permanent cart for at least 8 to 12 weeks after injury or like after surgery. Okay. Because if you put them in a wheelchair, sometimes they rely on the wheelchair. They may not want to use the hind limb anymore. I see that a lot in those like stoic dogs, Labrador or those Mastiff. They are just lazy dogs, right? So if they have something that to support them, likely that they don't want to use the hind limb. They would be like white borders, right? My mom picked me up, put me on the wheelchair, and I can walk well. And why do I need to like spend some time or energy to like push myself up and walking, right? So that's something that you have to be very careful. And because of that, I usually use the cart as a last resort. After 8 weeks, 12 weeks, if I absolutely know that the dog's not going to gain back the pain and not going to able to use the hind limb, then I would tell the owner, yes, this is probably the time that we probably need to use the cart and wheelchair and to help them to walk. That's one reason how I use it. Now, the other reason, in some cases, I actually do use cart during the recovery, but I only select those patients they're very active. They always want to get up and walk. And then because we know that the more that they walk, the more that they do gait patterning, the quicker they recover, remember, right? So, but without the wheelchair, when they get up, they kind of stumble and then they fall. So it makes them very frustrated that they could not get up and walk. So in that case, I would use the wheelchair maybe once or twice a day for maybe like 10 minutes. And I adjust the wheelchair, make sure that the dog able to bear weight on the ground. The wheelchair, basically, it just there to support them when they fall down, right? The wheelchair doesn't really give them any kind of weight bearing support, only for balancing support. So the dog can still walking, but when the dog trip themselves, at least the wheelchair would catch it. Then the dog rests a little bit and they can get back to use the limb again. And I found this type of treatment actually very helpful just because the wheelchair, again, is not permanently there to support weight bearing. It just like temporarily assist them walking and then help them to get back and using the limb quicker. Okay. I got this video actually from YouTube. So the dogs on wheelchair, it's much more work than you can expect. But sometimes at the same time they can get into a trouble. So this is a dog that on a wheelchair, and then when he start running, it really can like fast, right? So the owner couldn't even catch the dog. So now this is kind of dogs that during recovery, I would definitely not put a dog on wheelchair, because when I put a dog on wheelchair like that, they gonna forget about using the hind limb, because they know that they're gonna walk faster with the wheelchair. Like I say, why do they bother want to use that wheelchair, right? Because if they can walk faster with the wheelchair. So be very careful about this and have a good conversation with the owner, whether or not they are good candidate for wheelchair. Okay. Now, measuring feeding is very, very important. If the dog does need a wheelchair for long term, make sure that you get the custom made wheelchair, not the over the shelf. Okay, it has to be a custom made to fit well. All right, to summarize my talk, so here's a few key points that I would like you to take away. First, neurological cases can be challenging, but very rewarding. That's one of my favorites about rehab is I like to treat neuro cases. It always triggers my brains and try to find something to help them. So I actually like that. Recovery is rarely linear, and the progress varies widely depending on the lesion severity, how chronic it is, and the patient factors. So that's why that you have to be always be creative and like have a individualized plan for your patients. There's really no one size fits all when it comes to neurological cases. A clear diagnosis is always important because it helps us to set a realistic goals, communicate the prognosis, and also design the right kind of rehab plan for our patients. Start rehab as early as possible, right? So even though like during acute phase, you still can start the rehab, but you're going to more focusing on pain management and resting, right? Again, always phases driven and multimodal approach for those cases. Phase 1, 2 to 4 weeks, pain inflammations that you need to deal with. Phase 2, week 4 to week 12, you want to focusing on locomotor training. Phase 3, once the dog able to bear weight, then it's gonna take couple weeks, couple months to train for proprioception, strength, and endurance. Okay. And finally, remember that increasing spinal excitability or neuroplasticity, it's a very important thing when it comes to support motor recovery for spinal cord injury. So we learned that local training, gait patterning. We also learned that some modality could be helpful. Electrostimulations, acupuncture, electroacupuncture, shockwave laser, they have some literature or evidence showing that it might improve the neuroplasticity. Now, there's another one that I did not mention is a potential medications that call for aminopyridines that actually have been studied in maybe 2 or 3 clinical trials in dogs with IVDD and found that it helped to improve that neuroplasticity sooner and the dog able to get back and using the limb quicker as well. Okay, if you're interested, you can always look up that papers and look into that. I'm not going to get into that because it's not a medication on the market yet. It's just something that's been studied for IVDD patients. Okay, so I'm going to stop here and take any questions if you have any questions. Thank you again for attending this webinar.
Does anybody have any questions? Don't be shy. I'm getting great information. Thank you. Well,
Cindy, I have a question.
yes.
Hi, Ron. I was wondering with the prognosis with the IVDDs that you started out the presentation with, were those a prognosis both with or without surgery? Like, was there a differentiation whether the dog got surgical or conservative management?
Let me see. Without. So the ambulatory with intake depends actually is without surgery. They will still get a pretty good recovery by quick rest, medications, and of course, nowadays I would add rehab, and that help to increase that recovery. Non-ambulatory with depends. This is the one that actually with surgery. Yeah, I should put it down. Yeah, that's actually with surgery.
So I do have a question, Dr. Koh.
Yes.
I think it's a common question us as technicians run into, and more so in neuro than in musculoskeletal rehab. During phase 2 in particular, like what are some of the signs that enough is enough or we need to stop? We've stimulated enough for that session.
I always would say that short durations and more frequent is always better than one long durations. So that's a good question that I don't think we have a good answer for that. So I usually start with like short durations. At home, maybe like 15, 20 minutes. To me, that it's plenty. The owner can do it like 2 times, 3 times a day. I would want them to have enough time to recover before the second sessions, right? So especially that if you do a lot of like like toe pinching, you're going to contract the muscle a lot, along with like bouncings, along with e-stims. That can be too much for the muscles. Yeah. So I would worry that the muscle fatigue or muscle pain would be something that could happen if you do too much, and that might slow down the progressions. Now, after that, if the dog's starting to regain the motor and gets better and better, and then you can always increase the durations, like increase maybe like 3 minutes, 5 minutes at a time, right? Then you might do like 30 minutes twice a day and slowly increasing that. Yeah. So that's how that I would safely design my treatment plan for our clients, so that they don't overdo it. At the same time, they don't underdo it as well. There's actually a literature out of Brazil for IVDD dogs. They actually do much more intense rehab than I would recommend for my patients. They actually do like gait padding on the treadmill up to 30 minutes, followed by other exercises. Or underwater treadmill, they put the dog in the water for at least like 30 minutes, and they do it once a day or like 2 or 3 times a day. Now, actually, those dogs actually recover pretty well. So I think that we just don't know like how much is too much at these points. And again, there's a literature show that like intense rehab actually increasing the recovery rate. But also the study done at NC State a couple years ago found out that intense rehab does not increase any success rate. So we just don't know. Yeah.
Balancing it out.
Correct. Yes.
One question in the chat is, what is your positioning or your focal points when using shockwave for neuro rehab?
I would use low intensity. I would use a shallow penetrations, because at this point you don't want to give too much energy to the spinal cord that already inflamed. Again, I mean, there's no study to really prove that whether or not it's helpful or it's going to be hurtful. My take is that because the shock wave going to give a focal energy into the focal area, if the nervous system or if the spinal cord already inflamed, I just don't want to like aggravate it. I would rest. However, I would treat the surrounding area. I would use the shallow penetrations to the epaxal muscles. I use a low energy, just kind of do that surrounding area.
Perfect.
I guess would be a question for you too, right? Yeah.
Well,
You probably can, yeah. You probably
no,
read
well,
more
that
literature
was
than me. Yeah,
Well, I have to be careful because there's one rabbit study with very, very high energy where they show demyelinization of the cord. And as a conservative company, we recommend not treating the spinal cord. But
I agree. Hmm.
treating the peripheral nerves as they exit the spine,
Hmm.
I have personally seen tremendous success with that. So the
Hmm.
paraspinals and just deep enough to get to where the peripheral nerves exit. Um, so that is
Right.
my goal usually.
Yeah, me too. Yeah, I totally agree with that. That's how I approach my IVDD patients when it comes to shockwave.
The flip side
Hmm.
of that is the literature for the potential of traumatic spinal cord recovery in lab animals is amazing. I can't recommend that for our patients. So I hope that helps. For
Hmm.
piezo wave, how many treatments, how early to start? Use the shockwave near the problem area, and is it okay to use in other spine sites or not? So we just said
Hmm.
not to use it over the spine, Anna. And then the other one, how
Yeah.
many treatments, Dr. Koh, do you recommend? And when do you
I usually do, they usually come in once a week or twice a week. So if I usually do once a week, shockwave. Again, I do, like I said, I use the shallow penetrations, low energy. So I just gonna treat the whole entire spine. And am I focusing on the area that's mostly painful? But I also treat the area that I found that it's like tight. Again, anywhere that I found that it's tight, sore, that I would treat the whole area. I'm more focusing on like making the muscle relax because sometimes the pain's coming from the muscles along with the spines. So treating relaxing the muscles, however you want to use shockwave, laser, acupuncture. I think those are things that I would consider treating not just the lesion but the entire spine.
Right. I love
Mm-hmm.
that. And then
Yeah.
this is a question I get all the time, is how early post injury do you start when it's an IVDD injury, an acute IVDD?
I would say for again, if it is a post-op, okay. So post-op, I would probably avoid that incision area just because that now is very inflamed. Like I say, any kind of inflamed tissue, I tend not to do too much of the shockwave. I'm just worried that it might aggravate it. And then I would do like surrounding soft tissues, and that I would start a week after the post-op. I have no problem with that, just because I'm treating the surrounding area. Now, if it comes to that incision area, I will wait until maybe 2 weeks. Once the swollen gets better, then I will start doing the area. If the area is tight or painful, then I would do those surrounding area. Yeah.
Awesome. That's early. I mean, that's great. That's pretty early.
Mm-hmm.
I, because of a malmalasia, spinal malmalasia case, I always
Mm-hmm.
wait the 2 weeks that when they feel that can come on. Not that
Yeah.
shockwave would ever cause that disease, in my
Yeah.
opinion, but I don't want
No.
to be blamed for it.
Myelomalacia, if it happens, it happens.
Right.
Unfortunately.
And it's horrible, and I don't want somebody to turn
I
around and
know.
say,
Even neurologists, they're not able to predict that. It happened, it happens.
yeah,
Yeah. So even the most confident case that they have after surgery, it might still develop myelomalacia. So
yeah,
it
it's sad.
just, yeah. I think it has nothing to do with what we have like
Done
would
as a rehab.
do. Yeah. Exactly. Yeah.
Awesome.
Mhm.
Um, and then Dr. Weddle would like to know what intensity you consider low. Now, your low intensity is a little bit higher than my low intensity, but what is your low intensity?
No, I would definitely start with a 0.5. Yeah, I would definitely like 0.1 to 0.5. That's what I would do. I might go up to one. Yeah, but yeah,
So you're down in the decimal points on with the
yes,
F7G3. Yeah,
yes, correct. Yeah, yes.
right.
And I probably use like five, is that 5 centimeters or the
Five
number five, whatever
millimeters.
it is? 5
5
milliliters.
Yep.
Yeah, 5 milliliters. Yeah. Again, in the bigger dogs, like those like big dog, you might need 10. But I would probably stick with 5. Yeah.
Okay.
Smaller dogs, I might even stick with just like 0. Yeah.
Perfect.
Yeah. You can always adjust that. That's why I usually do like, I mean, they tolerated pretty well. It's not aggravate anything. A week or 2 weeks later, and might go a little bit deeper, and then we'll go a little bit deeper. So that's how I usually choose my depth. Depends on how they do and how they feel. Yeah.
Great. Awesome. Anybody else? Well, that was a lot of great information. Thank you for everybody who attended. Oh, one more. Perineal stimulation. Uh-oh, I lost it again.
Okay.
Perineal stimulation, is that just touching the perineal area?
Yeah. Scratch it.
Scratch it.
Just scratch it. You can use like electrode toothbrush, just kind of like stimulate the area. I just scratch it. Now, if you want to get a strong stimulation, now some cases, no matter how you scratch the area, they're not gonna kick the back leg. So I found one trick is that just go ahead and do the rectal palpations. That's why I wear gloves. I just kind of like put a lot of like lube and just kind of insert doing rectal palpations. A lot of dogs that they will start kicking back like crazy. So that's why I mean, like I have one hand like kind of supporting the tail and the other hand just doing like rectal palpations. You don't have to do it like consistently. I would just put it in, stimulating, they kick it, and then let them without stimulation to see if they would gait patterning. If they don't do it, I'll just do that again. Yeah. So, and then the downside is that be prepared to catch poop. So they would poop always. Yeah. So somehow I tell my technician owner, do that first just to get the poop out before we do that. Because, when they poop in the treadmill or underwater treadmill, it's just a mess. Yeah.
Big problem.
Yeah. Big
for us
problem.
technicians. Dr. Weddle has one final question. She says, but
Okay.
laser and PEMF, are you okay with laser and PEMF at the same time?
Actually, yes. Yeah. Actually, yes. So I think that's to be honest, I do think when you look at the literature, they actually share some of the mechanisms, even though there's some study might be conflicting because of the nitric oxides like release or inhibitions. But when you look at other literature, they actually share the same mechanisms that when you use them together, it might give you better results. So I use them all the time. Most commonly is that the dog lay on the PEMF mat and I do the laser. Or I do the
there's
acupuncture as well. Yeah.
Yep.
Go ahead. Sorry.
There's a company, a laser company or a couple laser companies who are worried that the PEMF signal will fry the laser, so they give us a recommendation of not doing them together.
Okay.
But I've never broken a laser using it on a PEMF bed or damaged a laser.
Correct. Yeah. That's a good question because it really depends on what kind of pen you use. I know that some pens they're so strong that they can actually move the metal, right? So the one that they use in horses, that's the one that I feel like is kind of scary sometimes because you can actually move that. I have my own pen for humans. So the way that I test whether or not the pen is working is that I put a metal spoon and then it would push the metal spoon away when it gives out the PEMF signal. So you can see that actually it's quite strong. I can see that why the laser company would want to avoid that because if you use the PEMF is strong, like high intensity, it actually can damage like metal part of the machine, not just laser. I would say pretty much anything. Yeah. So, and this is why that when the patient have like implant, like TPLO or any kind of implant that is metal, I mean, when I use PEM, I do be careful. However, the most common PEM that we use, like the PEM mat, the CC loop, I don't think they're strong enough to move anything. At least that when I put a metal in there, I don't see the movement of the metal. So I don't think that they're that strong, could damage a machine. But it's a high intensity of PEM, they actually could cause damage. That is true.
Yes. But I think most of us use a sissy and respond mats, and it's a very low intensity. So
Correct. Yeah. Unless you use the horse one, that you have to be careful. Yeah. So that's the one that can really like pull out the implant, to be honest. Yeah.
awesome.
Yeah.
Well, great, everybody. I'm gonna say good night and thank you, as we will all be back in at school at Chi
Yeah.
University tomorrow morning. So I appreciate
Yeah.
you attending and thank you for your time and effort, Dr. Koh. And
Thank
your
you so much. Yeah. All right. Everybody have a good night.
good night.